Hello everyone. Linda, Mitchell, Anthony, Jenny, Maria, and myself will be presenting on the topic of drug-resistant tuberculosis. What is drug-resistant tuberculosis? According to the Centers for Disease Control and Prevention, tuberculosis is caused by bacteria that are spread from person to person through the air. Drug-resistant tuberculosis results when the drugs initially utilized to fight against the bacteria becomes ineffective. This condition essentially develops due to the misuse and mismanagement of the prescribed antibiotics. For example, an individual doesn't follow proper guidelines of the treatment and does not complete the required intake of antibiotics. Thus, these individuals are more likely to become susceptible to drug resistance of the condition. Moreover, tuberculosis primarily affects the lungs. However, it can also affect other parts of the body, such as the brain, kidneys, or spine. Now, what exactly is the extent of the problem? Countries with the largest concentration of drug-resistant tuberculosis were China, India, and the Russian Federation. Together, the cases of these three countries accounted for 47% of the global total number of cases. The following research we will primarily be focusing on is drug-resistant tuberculosis cases in India. The World Health Organization conducted a report to show the number of tuberculosis cases worldwide in 2015. As you can see from the image, tuberculosis rates are highest in India at 2.8 million cases. The multi-drug resistant tuberculosis cases are also highly seen in this area as well. By definition, agent refers to the cause of a disease. In infectious diseases, often the agent is a microbe, such as a virus or bacterium. According to the National Institute of Allergy and Infectious Diseases, tuberculosis is a contagious and severe airborne disease caused by an infection with Mycobacterium MTB bacteria. The image on the left displays a microscopic view of the MTB chromosomes. When MTB is inhaled, the bacteria gets implanted into the alveoli within our lungs and forms a lesion or damage known as the Ghosn complex. Then, tuberculin reactivity develops. Again, as stated earlier, drug-resistant tuberculosis ultimately occurs when the initial antibiotics used to fight the condition becomes ineffective against the bacteria.
Next, we will talk about the condition and the mode of transmission of tuberculosis. There are multiple clinical symptoms associated with drug-resistant tuberculosis. According to the Mayo Clinic, TB can either be latent or active. When TB is latent, the bacterial infection is inactive and there are no symptoms. The infection is not contagious, but can be activated within a few weeks or years later. This is known as the incubation period. The incubation period is the time interval between exposure to an infectious agent and the appearance of the first signs or symptoms of the disease. The TB organism begins to replicate within the host during this time. Active TB is when an individual begins to show signs or symptoms, and the disease could spread from one person to another. According to the CDC, the location of the TB bacteria in the body determines the symptoms. For example, TB can spread to other organs but commonly grows in the lungs. Some symptoms of pulmonary TB would be a bad cough lasting up to 3 or more weeks, chest pain, or coughing up blood. Other signs of TB would be if the individual experiences fatigue, weight loss, no appetite, night sweats, chills, or fever. Mayo Clinic states the most commonly used diagnostic tool for tuberculosis is a simple skin test, and the patient would have a hard raised red bump on their arm within 48 to 72 hours. This is a diagram of the mode of transmission of tuberculosis. The mode of transmission is airborne. An airborne transmission is when microscopic droplets are released into the air and spread from person to person. The dots in the air represent droplet nuclei containing tubercle bacilli. According to the CDC, an infected individual may cough, speak, or sing to spread the disease. Some of the factors that determine the probability of transmission of TB is susceptibility, which is the immune system status of the exposed individual, infectiousness, which is related to the number of tubercular bacilli that he or she expels in the air, environment, which is defined as the domain in which the disease-causing agent may exist, survive, or originate, and finally exposure, which is proximity, frequency, and duration of exposure.
Mechanism of control. The CDC and the Science Health Allied Research Education has a collaboration program called Strengthening TB Action and Response in India. It is to build institutional capacity to improve drug-resistant TB treatment and adherence in Mumbai. They are working toward to improve TB lab quality, airborne infection control, and healthcare surveillance. They register TB patients and caregivers in the treatment adherence counseling services. It is to guarantee patients receive and complete their treatment. They are working with the public and private sector to improve access to different cultures in India, more drug susceptibility testing, and improving diagnosis and treatment of drug-resistant TB. Primary prevention includes educating individuals, spreading awareness, avoid exposure to known drug-resistant TB patients in closed or crowded areas, and improve the use of protective gears. In 2006, the revised National TB Control Program was developed. It aimed to reduce the rates of TB and spread more awareness about the condition and resources that are available for all individuals. Secondary prevention includes screenings and treatments, separating coughing patients and patients with TB, and increasing airflow in waiting areas. Many individuals in India are not aware of the healthcare services they are eligible to receive. RNTCP provides free diagnostic and treatment services. Tertiary preventions include taking all prescribed medication and treatment at the designated time frame. Healthcare providers must inform TB patients on the importance of their medications and the potential risk of drug resistance. Increase training, education, and counseling of healthcare providers in India to ensure proper services that are being provided to the society. Host factors that increase vulnerability to MDR-TB includes having prior treatment for TB, those with comorbidities, substance abuse being in the age group of 26 to 45, and is more prominent in males.
We will now investigate the environmental factors that make the people of India vulnerable to multi-drug resistant tuberculosis. To do this, we will examine the environmental epidemiology, which is the study of diseases and conditions occurring in the population that are linked to environmental factors. The main environmental factor increasing the susceptibility of contracting multi-drug resistant tuberculosis in India is overpopulation. Looking at the chart of the most populous countries, India sits at number 2 with just under 1.3 billion people. To better put this into perspective, New York houses 8.5 million people and about 305 square miles. On the other hand, Mumbai houses a population of 12.5 million people in an area of just 271 square miles. Overpopulation is linked to many health disparities that increase the transmission of multi-drug resistant tuberculosis, which will be discussed in the next slide. In the photo to the left, this is typically what a city in India looks like. Overpopulation in these cities result in health disparities such as low socioeconomic status, poor living conditions, high rates of non-communicable disease, and improper access to health services. These poor living conditions increase vulnerability to any disease, but especially to multi-drug resistant tuberculosis. Due to the overcrowding of streets in India, this creates an easy opportunity for transmission of multi-drug resistant tuberculosis. As mentioned before, multi-drug resistant TB is spread through the air from coughing, sneezing, talking, and singing. Once a person who is infected coughs, the bacteria can stay in their surroundings for up to several hours. There are hundreds or even thousands of people breathing and sharing the same air, creating an easy pathway of transmission.
We'll now talk about temporal variations in regards to tuberculosis. These variations include seasonal trends. A study concluded that diagnosis for tuberculosis is heavily seen during the spring and summer seasons in various countries such as South Africa, India, Hong Kong, and more. Results also indicate that the higher risk of tuberculosis transmission is during the winter months because of vitamin D level changes, indoor activities, weather influences on the immune system, and delayed healthcare services. Tuberculosis is an endemic disease in India. Endemic is a disease that is regularly found in a certain population or area. In northern India, tuberculosis peaks during spring and summer, but in southern India has no seasonal pattern. Due to the weather differences between both regions, cases and rates of tuberculosis vary. Higher demands of treatment causes difficulty to access resources and receive proper diagnosis. Drug-resistant tuberculosis is something many people are unaware of, which causes many gaps in knowledge. Information on mortality and morbidity are inaccurate for drug-resistant TB because of the troubles in diagnosing. There are many cases that are not being identified, which causes patients to not be treated. This contributes to further spreading drug-resistant TB. The evidence-based researches are limited, which causes limiting guides for doctors to practice off from. In India, a contributing factor leading to gaps in knowledge about TB is the lack of laboratories. There are only 14 validated and certified laboratories in the country as of December 2009. This causes the turnaround time to diagnose drug-resistant tuberculosis cases could take several weeks or up to 3 to 4 months with this current technology. This means that there is an insufficient amount of resources available to quickly pass on information, thus contributing to the gaps of knowledge in India. There is also an inadequate assistance international. India relies heavily on grants to be able to afford tuberculosis treatment programs. This causes issues with proceeding programs and treatments because it is unpredictable if there will be supplies.
So for further epidemiologic research, some suggestions. There should be more research to define the true magnitude of the problem happening in Mumbai, India, because it's a low-income area, so there's very little laboratories available for testing. So there's not enough laboratories for people to go in and be diagnosed, so we don't really know how many people truly have drug-resistant TB. And we should also be using current available tools and work to develop new tools to optimize TB diagnosing, treatment, and preventions in dense population areas, because it's a huge problem when an airborne disease such as TB is out there in dense population areas, because it's spread a lot easier, and we need to use these tools that we have and develop new ones to make sure that it's controlled. There also should be communications between researchers so they can discuss ideas and findings that may lead to further epidemiologic discoveries. And there should be a formal guide created regarding the identification and treatment of TB patients for doctors and health professionals to follow in the area, because by following an organized process, it makes diagnosing and treatment more efficient, which is really important in high population areas because you really want to control it like as fast as you can and as efficient as you can so it doesn't spread anymore. And especially in low-income countries, there's not a lot of healthcare available and there's not a lot of restrictions on that. So these doctors and health professionals who are out there need to formally know what to do. And lastly, there should be research investigating the cost of drug-resistant TB treatment in low-income areas, such as India, and how it affects treatment rates. So can the affected individuals even afford to be cured? And is that affecting the amount of treatment that people are going in for? Alright, so just to conclude, as prior mentioned, TB is an airborne disease which can become drug resistant due to incorrect or incomplete treatment. Drug-resistant TB is concentrated in highly populated areas such as Mumbai, India, which is what we were talking about during this presentation. So these areas have low socioeconomic status, little access to healthcare, and these dense populations allow airborne diseases like TB to be spread really easily. And why we deserve the money is because research is very, very lacking. And we need to understand the extent of the problem, and we can't do that without money. And with unclear data, there's going to be insufficient treatment plans and guides, so we won't even be able to treat these people effectively because we don't really understand the extent of this problem. So we can't have a plan if we don't know the problem. And then there aren't enough laboratories available for testing either, so we can't even diagnose anyone, or we can't diagnose everyone, which is a big problem. So also vulnerable populations are unable to get access to quality health care and treatments, as mentioned before. It's a very poor area, and they don't have the money or the supplies to keep up with the demand of treatment, so a lot of people out there are being left untreated. So this is why we need the money, so we can work to improve the health care of these people and help diagnose them and make treatment more available to them. Thank you.